Hi, I'm Christie Ballantyne. I'm here at the National Lipid Association meeting in Miami. I'm pinch hitting for Alan Brown. I think he was playing music last night or something. We stayed up too late, but anyway, I'm here to discuss. We had a joint publication with the American Society of Preventive Cardiology, also in JCL, on persistent chylomicronemia, recognition and management, and I'm here with authors of the manuscript. And we're going to take you through this approach, which we think is something that's very pragmatic. I'm going to let everybody introduce themselves, and we'll go first, Daniel.
My name is Daniel Gaudet. I'm a professor of medicine at the University of Montreal. For a couple of decades now, having developed interest in rare and severe lipid disorders.
Yes. Hi, I'm Erin Michos. I'm a professor of medicine in the Division of Cardiology, our Associate Director of Preventive Cardiology, and a member of our Advanced Lipid Clinic at Johns Hopkins University.
And my name is Mohammad Saadatagah. I'm a cardiology fellow at Baylor College of Medicine with a specific focus and interest in preventive cardiology and lipid disorders.
Okay, so, in general, there's a lot of confusion about triglycerides, both from patients and I think also from physicians. So let's start off with some of the basics. And I'm going to start, Daniel, with you. If you could talk about, when we talk about chylomicronemia, or people talk about severe hypertriglyceridemia, and then, some of us still remember these Frederickson classifications of type 1 and type 5 and type 4. Can you take us through what is a chylomicron versus a VLDL? Let's start off with some of the basics on that.
Yeah, sure. First of all, triglycerides, obviously, we're talking about fat. Fat would be floating in blood if they were free. So they are transported in transporters, making them deliverable to the different tissues and cells. So the different lipoproteins have different names because they come from different sources. Let's start with chylomicrons. Chylomicrons are the largest, the biggest transporters of fat. Why are they large? Why are they big? The reason is that they are transporting fat after a meal. And after a meal, there is a bunch of fat being delivered to the body. So to transport them, we need a large transporter. And these chylomicrons, once secreted by the enterocyte, they are too large to be delivered as they are. So they should be shrinked. And this requires hydrolysis of the triglyceride that they transport. So this is done through a critical step, which requires lipoprotein lipase, LPL. LPL is the key enzyme in large lipoprotein, TG-rich lipoproteins hydrolysis. So if LPL is lacking one way or another, or is deficient, or is not bioavailable, the duration of stay in the bloodstream of chylomicrons will be longer. It could be very, very long if you completely lack LPL. This is for one part. So chylomicrons are transporters of fat from what we call the exogenous pathway, fat coming from outside the body. As for VLDLs, they are the largest lipoproteins being produced by the body, specifically by the liver. VLDLs transport endogenous fat, and then they also require hydrolysis to deliver their content. So here again, we need LPL. If again here LPL is deficient, the duration of stay of VLDL will be longer, and in this case, and that the difference between chylomicrons, by the way, and in the VLDL is that they are constructed around the backbone, which is a little bit different. Same source, but a little bit different. Chylomicrons are built around ApoB48, which is a truncated ApoB. VLDL, the backbone is ApoB100. So if you accumulate chylomicrons because you completely lack LPL, the odds are that you will be less able to produce VLDLs. So in this case, your ApoB100 level will be low because you'll produce less VLDL. So chylomicronemia can be the consequence of pure accumulation of chylomicrons because you completely lack LPL. In this case, ApoB will be lower, or a combination of both, accumulation of VLDL and chylomicrons. In this case, ApoB will be, in general, higher than normal.
So if we go back to these Frederickson classifications, what was a type 1 again versus a type 5?
Well, there is a guy called Frederickson with colleagues, ladies and ladies, in the mid-1960s. It very elegantly classified the different lipoproteins and their consequences by number. So type 1 identifies patients with accumulation of chylomicron only. This is a form of chylomicronemia. Type 5 identifies patients accumulating both chylomicrons and VLDLs. These patients also have chylomicronemia, but it is not a pure chylomicronemia, if I can use the term. It's and by the way, if you look at the Frederickson classification, all classes except one are linked or associated with hypertriglyceridemia, just illustrating that the TGs are more complicated than cholesterol.
So, and you mentioned this issue of prolonged time in the circulation, and I think this maybe goes back, Erin, in terms of a clinical question, getting fasting lipid panels. So it is, how much difference does it make in terms of when you see high triglycerides getting a fasting panel, and we talk about 10 to 12 hours overnight fasting versus someone who just walks in the clinic and maybe they had a big breakfast or something, which means they might be in the postprandial state.
So for generally when clinicians are focusing on LDL management, you get most of the information from a non-fasting lipid panel. The LDL is not influenced that much by fasting state. And so a lot of times it's just so much easier for patients to get their blood drawn when they come to clinic. And sometimes it's really hard to go in the morning to the lab first thing. And so for convenience, the 2018 ACC cholesterol guidelines has said that, for most patients, a fasting lipid panel is not required because that's just because we want to do a better job of just getting patients getting their follow-up lipid panels. It's better to have some information than no information. But obviously the fasting state really influences triglycerides. And so if there is a triglyceride disorder that you're following and tracking, the fasting lipid panel is quite important for those patients.
So because of this issue of the fairly rapid clearance of chylomicrons, we do an overnight fast because they're mostly cleared out, and that'll give you an idea of the true levels of, although it's still informative sometimes if you get someone who comes in and even in the postprandial state, if they have very elevated levels of triglycerides, you should be concerned they may have some kind of major problem with that.
It's your lipid stress test.
Yeah. So now the other one that comes up sometimes in terms of the lab results, and so, well, I'm sure seen this sometimes. What does the lab say sometimes about the specimen? Or do you want anybody, if someone really has chylomicronemia, frequently there'll be something on the lab result. Mm-hmm. What does it usually say?
If you are lacking LPL, or if your LPL is less efficient, after 12 hours fasting, there will still be chylomicron circulation. So when you draw blood, the blood sample, if you let it on the table, there will be a white color. This is because chylomicrons are floating. And chylomicrons, if they contain cream, it's like having 10% cream in circulation.
So in fact, if we think about cream, and milk. So this is why it looks like that, because that's basically the type of fat that you have in there. Now, and sometimes you'll have the laboratory will have some problems in regards to some abnormal lab readings because of the extreme elevations of triglycerides. So that's just another issue that be a little bit cautious about. They have to dilute the samples to be able to measure triglycerides accurately. And some of the labs most of the labs do that appropriately now, but you still could have some occasional problems. All right, so with that in mind, now let's talk about chylomicronemia. It's not a common issue, but most people will end up seeing it at some point. So what is the prevalence of this in a population, Erin?
Yeah, so let me just talk about sort of the statistics about hypertriglyceridemia, and then we'll get into PC, or persistent chylomicronemia. So, generally, we consider triglycerides less than 150 milligrams per deciliter as normal, although one would argue that ideal is probably even much lower than that threshold. So moderate hypertriglyceridemia is your 150 to 499 milligrams per deciliter, and that's about 26% of the population. So that's incredibly common, and we see it associated with so many comorbidities, cardiometabolic diseases, and obesity. So severe hypertriglyceridemia is defined at levels above 500 milligrams per deciliter, which is about 0.9% of the population. But we really don't start to see pancreatitis risk until we get to these extreme levels. So extreme hypertriglyceridemia is levels above 1,000 milligrams per deciliter, and that's about 0.2% of the population. Now, for most patients, and we can go over some of the work you've done to demonstrate these, triglycerides goes up and down a lot in patients based on, different stressors and compliance with lifestyle and medications. And so there's individuals, and again, we care about this extreme hypertriglyceridemia above 1,000 milligrams per deciliter because that's in the range where we're seeing chylomicronemia. So there's patients who have sort of non-persistent chylomicronemia, where they may have some readings above 1,000, but many times when they're well controlled with their medications and their lifestyle, they're below this threshold. But then there's individuals who have persistent chylomicronemia, and that's about 9% of this extreme group. And this is part of our scientific statement, is we wanted to better characterize and define this persistent chylomicronemia group.
Okay, so now I know, Mo, you looked at the changes in triglycerides over time in the enhanced population. So first of all, which are there demographic characteristics of the people who are most likely to have high triglycerides, and how has that changed over time?
Sure. So as we discussed, the prevalence of the chylomicronemia in general in the population. And first of all, we, as Dr. Gaudet mentioned, in an ideal world, we need to have chylomicronemia and VLDL measured separately in order to being able to identify chylomicronemia. So that, because we don't have it usually in most of the lipid panels, that's the reason that we define this extreme hypertriglyceridemia. And we stressed out on that definition in order to separate it from severe hypertriglyceridemia, which is about 500.
What value? So for most people in the United States, we use one cut point. In Europe, they use another one. What are the usual thresholds that we start to say is that most likely you have chylomicronemia?
Sure. So usually when TG, like fasting TG is about 750 milligram, you are going to start seeing chylomicrons in the blood. And when it's about 10 millimole or 800 AD or like 1000, which is the cutoff, very strict cutoff that here we use in this, is almost always that's indicative of chylomicronemia. So with that definition in mind, the prevalence of the chylomicronemia using the enhanced data set that we used from 1999 to 2018 was 0.2% in the population. There are two important things here that I would like to stress. First, this prevalence varies based on the sex, age, and ethnicities. The prevalence is higher, close to 0.3% in men compared to women, and in the middle age group, 40 to 59, and also in those with Hispanic ethnicity. On the other hand, we also used in the temporal trend using the enhanced. And interestingly, all level of hypertriglyceridemia, mild, moderate, severe, extreme, show the downtrend pattern. There's like lots of conversation we can have about the reason of this downtrend pattern, but part of that could be because of higher use of lipid-lowering treatment in the population. If you look at the enhanced data, in the first few years, only 3% of the people with chylomicronemia were on any lipid-lowering treatment. This number increased to 30 and 50 and 60% over the study period.
So observational data, but basically what was shown is that as you know, we have many good lipid therapies, but the use of fibrates, statins, omega-3 fatty acids, as there was an increased usage of these agents, there was a decline in both severe 500 to 999 and also over 1,000, which gets to this other point. Now, what about the demographic factor besides what you mentioned, medical conditions? So did you see a difference, for example, obesity, diabetes, or other factors in terms of
Absolutely. Yeah, we also saw a really robust pattern of the association with features of the metabolic syndrome. So obesity, diabetes, alcohol use, these were the very three strong things that were associated with higher TG level, even on the extreme hypertriglyceridemia level.
So I think this issue of obesity and diabetes is really important for the clinicians and the patients. And we'll go back to Daniel, what you said at the very beginning. The purpose of chylomicrons is to deliver energy, essentially. This whole, and we talk about cardiometabolic disease, but in terms of metabolic disorders, just touch a bit more in terms of the link between diabetes, energy metabolic defects such as diabetes, insulin resistance, and then fatty acids. So to give a little bit of more insight to our audience as to why this is linked.
Well, the main reason isn't the structure of the triglyceride per se. I mean, triglycerides are three fatty acids linked to one glycerol. Glycerol per se is a glucose precursor. Fatty acids are insulin modulators. So if you break down triglycerides, you render available all the modulators of glucose metabolism. So now, translating this physiologically, metabolically, you store energy in the form of fat. You use energy in the form of sugar. So it's important, essential, that there is a very, very well-tuned communication between these two systems.
So, and just to make it clear to everybody, when we say you store energy in fat cells, how is it stored?
Well, it's the adipocytes are the cells storing, yes, and the muscles are the cells using. Right. Well, if it's more complicated than that, but I mean, it's
you have triglycerides in, yep, your fat cells, right? I mean,
mm-hmm,
basically, yeah. And so one thing that comes in at night when you have this metabolic syndrome is those adipocytes are releasing, yep, fatty acids, yep, in the portal circulation to the liver. What does the liver do?
Well, the liver is the manager of all this. They receive messages from insulin, fatty acid, etc., and they build the LDLs and they store fat. You know, metabolic syndrome is also associated with fatty liver. This is part of the metabolic syndrome. And fatty liver, by the way, it's a lipid disorder by nature. Having said that, just to come back to the principle of persistent chylomicronemia means that you lack LPL bioavailability. That's the reason why chylomicronemia is persistent. This could be due to lacking the capacity to produce LPL. LPL deficiency is associated, could be due to all the mutations in the different genes that are known to being part of the LPL machinery, but also could be kind of an LPL resistance. The word doesn't exist, but in multifactorial chylomicronemia, those with the metabolic syndrome, the features of the metabolic syndrome being chylomicronemic persistently, they most likely have the capacity to produce LPL, but LPL is less efficient for different reasons. That's why despite the control of secondary causes, despite using LPL dependent agents such as fibrates and others, their chylomicronemia persists.
So I think now we're getting to the crux of why we wanted to make this statement. And so one of the issues that comes up is in terms of what do you do when you see chylomicronemia? And then what happens if it's persistent? So maybe we'll start off a little bit with some of the data. You look longitudinally in the Mayo database about who gets chylomicronemia and was it persistent or not persistent. And because one of the concerns that we have with chylomicronemia is acute pancreatitis. So tell us a little bit what you found.
Sure. So as you mentioned, Dr. Ballantyne, this statement was really an effort to simplify our approach to diagnose and treat patients with chylomicronemia, we focusing on the risk of the most severe complication, which is acute pancreatitis. So in order to achieve that, as you mentioned, we defined this term persistent chylomicronemia. So we talked about the first part, the second part actually, the chylomicronemia. But what's really hard to determine is the persistency of the chylomicronemia, because the TG in nature, the TG level is so volatile and fluctuating. For example, if you look at the patient with the most severe forms of hypertriglyceridemia, like genetically confirmed, even though sometimes may have TG level in the range of like 300, 400, as we see in the BALANCE trial. So it was really hard to determine who should be considered persistent. For example, does one TG below 1000 exclude you from being persistent chylomicronemia? In order to do that, you need to look at the very large data sets who has longitudinal data. Because of that, we use at the Mayo Clinic database, which had almost more than 4 million, 4.5 million TG measurements for 1.2 million participants over the time. And what we saw is that the prevalence of one episode of chylomicronemia in the entire Mayo dataset was close to 0.4%.
That's over a 10-year period, though, right?
Or yeah. And then we looked at the temporal trend of those patients who had multiple TG measurements. And we looked at the different cutoffs of like the TG above 1000, like 50%, 60%, 80%, 90%. And then studied the prevalence of the pancreatitis in these populations. So we saw that actually if you have your TG, like your TG above 1000 in more than 50% of the TG measurements, the risk of pancreatitis is quite high. I'm going to go over the numbers. And when you use the stricter definition, for example, 80% or 90%, the yield doesn't increase. So you are going to lose lots of patients with chylomicronemia without increasing the prevalence of the pancreatitis. Because of that, we came up with this definition of persistent chylomicronemia being called as TG above 1000 in at least half of the measurements in those with multiple TG measurements. And if you look at the number of pancreatitis, the prevalence of the pancreatitis in this population, so let's start with the most healthiest group, those who have TG. The maximum TG in the study period was less than 150. The prevalence of the pancreatitis, I'm going to round the numbers for the sake of simplicity, is 1% in those populations. If the max TG is between 150 to 500, the prevalence goes to 2%. 500 to less than 1000, it's 4%. So basically doubling up every time. And then when you go to chylomicronemia group, the non-persistent is 13%, and persistent group has 26% occurrence of acute pancreatitis during this study time.
So quite a high number. and with a very simple way for a clinician is if you had chylomicronemia and then you treated it, and if it was persistent, those patients were very high risk. So let's go into two aspects. One of them, and you mentioned the nomenclature, FCS and MCS. And I'm gonna first talk, Erin. You know, we, those of us in this community, we're lipid specialists, but that nomenclature is a little bit confusing, I think, to people in practice. And you want to kind of go through some of the aspects that make it a bit confusing.
Yeah, well, first, I'll just go sort of, a little statistics for background. So familial chylomicronemia syndrome, or FCS, it's about 1 to 10 in a million in the population. So it's very rare because it's biallelic, autosomal recessive, and that's because there's really have no functional LPL. These individuals don't respond to traditional therapies, typically present in childhood, and have a very high pancreatitis risk. Now, multifactorial chylomicronemia syndrome, or MCS, is much more common, 1 in 250 to 1 in 600. But this is very much has a genetic component. It's typically polygenetic, associated with other comorbidities like obesity, diabetes. can have some response to traditional therapies, but can be at increased risk for pancreatitis. And because there's so many more MCS patients, often the prevalence of pancreatitis, we see a lot more in the MCS than the FCS, just because there's a lot more MCS individuals. But this is confusing because with FCS being autosomal recessive, it has familial in the name, but being autosomal recessive, they may not have had a parent identified as having chylomicronemia. On the other hand, MCS, which doesn't have familial in the name, they often have other family members who have had triglyceride disorders because of the polygenetic risk. So this gets really confusing. And of course, FCS, there are individuals who have genetically confirmed FCS, and then there are clinical scoring systems out there for FCS. So we have in this paper really come up with 4 groups of individuals. So there are those that have genetically confirmed FCS, those that have clinical FCS by meeting the criteria in the scoring system. And then there are the persistent chylomicronemia groups. There are individuals with PC who have alarm features, and we define these alarm features to align with the inclusion in the Palisade trial, so we'll talk more about that. But the alarm features are recurrent acute pancreatitis, recurrent hospitalizations for severe abdominal pain, having a history of childhood pancreatitis, this family history of hypertriglyceridemia-induced pancreatitis, or having post-heparin LPL activity less than 20% of the normal value. So individuals who have PC with alarm features, they have a very similar high risk of pancreatitis, similar to genetic and clinical FCS. So we call those 3 groups, the genetic and clinical FCS and the PC with alarm features, as individuals at very high risk. And then there are the individuals with PC who do not have the alarm features, and they're still at high risk, but not very high risk. And so that was the framework of the 4 groups that we defined in the consensus statement. And we defined these groups because sort of recommending therapies, including some of the novel therapies, the ApoC3 inhibitors that we'll talk about, likely would benefit individuals with the at the very high risk groups, but maybe not the PC at very high risk without the alarm features.
So, Daniel, I'm going to go to you now, because you've been getting referrals for many years of these difficult to treat patients, and of people who've had pancreatitis. In my experience, it's really the infrequent, it's the rare one who has biallelic FCS. It's much more common, and it is frustrating because many of these people do have a pathogenic variant in LPL. They may have a bad polygenic risk score, and so I can't really say it's not genetic to that individual. It is genetic. Now they may have other factors in there, but it unfortunately sounds, when we say MCS, as if it's just bad diet or something else. But in particular, when we get to these novel therapies that are being focused on FCS, so 2 questions: do they work with people who are MCS? And the other one ends up, I know you were involved with the developing some of these criteria, and this was in the trial with the Palisade, to be able to expand a little bit these people who we know clinically are extremely high risk. Can you talk a bit more about how that came to be in that study?
Yeah, again, it comes to the fact that there are patients lacking LPL functionality, and all these patients, if it's persistent, they share something in common. Their inability to hydrolyze their triglycerides persistently, chronically. So they accumulate chylomicrons. They tend to accumulate chylomicrons persistently, and this contributes to the acute pancreatitis risk. Let's start with that. So then the 3 groups of these patients, the biallelic FCS, easy if you have access to genotyping to identify, and it's not all sites having access to genotyping, by the way. Right. Let's start with that. So it's important to facilitate the life of clinicians in that way. The clinical FCS, then, as you said, there are some of them we can identify clearly. In the majority of the case, I think at least one pathogenic variant causing FCS, but not the combination of biallelic. So in recent trials, which we evolved, we evolved. The term evolved, by the way. The term familial chylomicronemia syndrome is recent. You know, historically, it has been called, and I'm not talking the 18th century, I'm talking in the 1960s, 1970s, it was called essential hyperlipidemia, idiopathic hyperlipidemia. So, and then in the 1980s, Chait and Brunzell came with the name familial chylomicronemia. And then 10 years after, the word syndrome has been added. But as explained, it's not familial because it's autosomal recessive. So let's try to simplify things. FCS exists, okay? No matter, and we will live with that, with the name. I'm comfortable with the concept. So, but however, there are clinical FCS, those not having the biallelic combination, but having the same phenotype, low ApoB, lower ApoB, not responding to LPL-dependent agents. And then the group of patients having multifactorial chylomicronemia. And you come back to the, if you come back to the Frederickson classification, these individuals, persistent chylomicronemia, MCS, have type 5. But they are the majority of patients, the 1 over 5 to 600, they are fluctuating type 5. Sometimes have type 5, sometimes they don't. So what we are looking for is those permanently type 1 or permanently type 5. These are the patients to be treated.
So it's a pretty simple way to identify the high-risk people. Now, let's go through the flow diagram, because the first step is very important in regards to intervention. And Erin, you want to just take us through that, because it's very important when you see chylomicronemia. There's things you need to do in terms of recognition, secondary factors, and treatment. You want to take people through that?
Yeah, so you first start with a diagnosis of having extreme hypertriglyceridemia by having a triglyceride value above 1,000 milligrams per deciliter, fasting. And so, of course, everything starts with a history and physical exam. So you need a detailed history, including family history, physical exam for other stigmata. You want to review their lifestyle. And this is where first line therapy is intensive lifestyle changes, a fat restriction and diet, and the first line treatments, because we know people with triglycerides above 1,000 are at risk for pancreatitis with statins, fibrates, and omega-3 fatty acids. So then after all of that's implemented, we then look at the group who have persistent chylomicronemia. So despite intensive lifestyle changes and standard therapy, they've had triglycerides above 1,000 in over half their samples, or at least 3 measurements above 1,000 milligrams per deciliter. And so that meets the criteria for persistent. And at this point, if this is being seen by somebody in a primary care setting or other cardiology setting, you may consider refer to a lipidologist to help aid in here. And this is where then you can consider advanced lipid testing. You can consider genetic testing. Think about your FCS clinical scoring systems. And part of this history, of course, is have they had a history of pancreatitis? Have they had a history of severe abdominal pain? And then our algorithm goes into, is this somebody who has genetic FCS? Is this somebody who has clinical FCS? And is this somebody who has PC, persistent chylomicronemia with alarm features, or the fourth group were PC, who are at high risk, but they have not yet had an alarm features.
So a pretty straightforward clinical algorithm. If you can get genetic testing, that's great. But if you don't have to have it, you can simply look at lipid profiles and clinical features. The alarm features are pretty straightforward. Now, and what was shown, now the Palisade study, I think the frequency of the individuals with alarm features is about 20% pancreatitis in 1 year. But talk to us about the new treatment options for individuals, at least with FCS right now, because it's really very exciting what's happened just in the last few years.
So yeah, there are new agents being developed and succeeded in filing for one, for FCS, because it's a rare disease to start with. But persistent chylomicronemia is also rare. The way it has been defined in the consensus paper. The key here is to make these treatments available for those who require it. So there are two purposes. I'm not responding directly to your question, but I will come to it.
Yeah.
There are two purposes of this consensus. First of all, simplify the clinical approach of patients having high pancreatitis risk due to severe hypertriglyceridemia, and some of them have a combined risk of atherosclerotic cardiovascular disease and pancreatitis. Okay, the first reason is that. The second one is for equity, making agents being effective on persistent chylomicronemia, being available for all patients requiring it. So coming back to the first agents being developed, they are ApoC3 ASO. The first one having been developed was volanesorsen. Volanesorsen was a second generation oligonucleotide antisense. The development has been stopped and replaced by a GalNAc conjugated version. But volanesorsen, we learned a lot about it. We learned, first of all, that inhibiting ApoC3, because here we're talking about inhibiting ApoC3 as a principle of action, is obviously LPL mediated its efficacy. But we have learned that there was also an LPL independent mechanism by which ApoC3 inhibition might manage chylomicrons, VLDLs, and all TG-rich lipoproteins. So inhibiting ApoC3 became very rapidly, and this has been published 11 years ago, so it moved very fast. It became a good target to inhibit in patients with persistent chylomicronemia. It started with FCS because it's the most severe form. So the first studies have been conducted on the principle of recruiting, randomizing patients being biallelic carriers of pathogenic variants in FCS-causing genes. But we realized that there were patients who failed in screening because they were not carrying the biallelic combination, but they were phenotypically clearly FCS. And by the way, I come back to the volanesorsen. It's a long story, but there were two studies being conducted after the proof of concept studies. One was called Approach. This trial was recruiting FCS patients specifically, and the other one, Compass, patients with severe hypertriglyceridemia, but not being FCS. But in the real life, and that's exactly what will happen, there were FCS being randomized in the Compass, the non-FCS study, and non-FCS patients recruited in the Approach trial. So this is the real life. So after the first studies having been conducted with the volanesorsen, went the GalNAc conjugated agents, olezarsen, which is an ASO, and plozasiran, which is an siRNA. In the olezarsen trial, BALANCE trial, patients were screened on the basis of the phenotype, but randomized on the principle of being biallelic carriers, the pure FCS. And that's exactly the reason why the trial was conducted. It was a good reason. It illustrated that it works in complete absence of LPL. But again, there were patients screened failed in the study because they didn't carry this biallelic combination. So in the PALISADE study, the decision has been made to open the door to these patients not being carriers of biallelic combination, but having features of FCS. And there were a set of criteria that have been used in the consensus paper that allows the inclusion of patients with clinical features of FCS. So we introduced the term of clinical FCS, maybe because we don't know the genetic cause of this, maybe because it's not purely genetic, might be epigenetic or others, doesn't matter. Clinically, it should be simple. For the clinicians, if you have a patient with persistent chylomicronemia, it would be a pity if there is a refusal to access to treatment because you are not carrying a biallelic combination. It's not semantic here. I'm not talking about what is FCS or not. I mean, there are the FCS phenotype, and that's why clinical diagnosis scoring system have been developed. So, ApoC3 inhibitors are working whether or not you have LPL bioavailable. Life is simple with this principle. And I just add something else. There are another class of agents being developed, ANGPTL3 inhibitors. They work in severe hypertriglyceridemia, but ANGPTL3 inhibition is LPL dependent. It's an upregulator of LPL, a huge upregulator, and particularly with the combination of ANGPTL8. So it has been shown that in patients with FCS, clinical or not, ANGPTL3 inhibition doesn't work. So again, I come back to the real life. If you use an LPL-dependent agent, a fibrin, and the patient doesn't respond, it's a sign that it might be because LPL is not bioavailable. And this is a criterion used in clinical diagnosis scoring system. And if you use an ANGPTL3 inhibitor in the future, because it's not available now, it could be diagnostic. If a patient doesn't respond, you have persistent chylomicronemia.
All right, so I think we'll summarize here that basically persistent chylomicronemia. So if you recognize that the patient has chylomicronemia, Erin, you went through looking for secondary factors, control glucose, diet, exercise, alcohol cessation, treat fibrate. You can use statins with that, omega-3 fatty acids. Mo, I think you showed over 90% responded, right?
At least partially.
At least partially. So they got below 1,000. Doesn't mean they got to normal, but and then the risk goes down. People who are 50% are very high risk individuals, and these individuals, if they have alarm features, could have gone into the Palisade study, and they had an event rate that was 20% in 1 year, which is extraordinary. But overall, 26% of the people with persistent chylomicronemia had pancreatitis. Even the group that doesn't have the alarm features, I would say those people need special attention, would benefit from seeing lipidologists with comprehensive care with that. So I think it was really, Erin, it was great to do this with ASPC. We've been trying to do this, and we want to make a change so that there's an understanding that both organizations, we were fortunate we did this with the LDL quality metrics, and finally now we have that's back into the ACC quality metric. Hopefully we can make the same kind of success here. So he mentioned a couple of things here, Daniel did, about also cardiovascular risk, Mo. So there's a whole other story about this, right? That
Absolutely. And I think it comes back to the way that we think about the disease, the most important complications, and how to mitigate the risk. So if people, I would encourage everyone to look at least a part of the paper that we talked about and compared chylomicronemia with the concept of like a familial hypercholesterolemia and how these things might be related, and why the reason that maybe we approach one the other way, and this needs to be changed. But I would like to emphasize on the concept that Dr. Gaudet mentioned. The Palisade was just like opening the door for these people, and there would be potentially lots of needs to study these alarm features in a larger data sets. Maybe there are other alarm features. For example, maybe different people have different threshold for pancreatitis. Maybe the pancreatitis risk based on the genetic risk for some reason for some people may increase at the level of 500, in other at the level of 2,000, and there's like a huge variability. So, and again, in addition to that, it also comes to the cardiovascular risk. So at the end, you need to think about all the benefits that you're going to get from the intervention, and basically compare that with the cost of the medicine that you're giving.
So stay tuned. It's just a very exciting story. We're in the early stages of it. Where our goal of this is the same way we look at treating LDL cholesterol. We don't have to get genetic testing. If someone has an LDL of 300 or 350 and they don't respond to a statin, we know we need to do more. So it's a similar concept here. If you mentioned, if they don't respond to traditional therapies, they don't have LPL activity sufficient to it, we have the opportunity to do more on that, and it'll be an evolving story. Lots more trials underway, lots more agents being investigated. It's been our pleasure to be with you here today on this podcast. Thank you for joining us.
Thank you.